Good evening and welcome to the Doctor's Corner on CAW 360 Network. I'm your co-host Janelle Elgaway and we are here with Dr. Kline. Welcome, Dr. Kline.
Good evening.
How are you doing this evening?
I'm just dandy.
Good. If you have a question tonight for Dr. Kline, please call in at 415-915-2291. You can also chat live with our audience on YouTube channel Conspiracies Against Wellness. Well, Dr. Kline, so what have you been up to lately and what's going on that we need to hear about?
Well, I've been monitoring the news, and over the past week, some good things are happening.
Okay.
It looks like Gottlieb, the head of FDA, is definitely interested in expanding treatment for people with addiction by using opiates, as we did in 1915 before the government took it away from us. Mm-hmm. He does also sound friendly toward the pain patients. Apparently, the White House is calling some agencies together, rumor has it, to look into the problem of chronic pain patients. I think it's starting to catch the eye of the White House, which is good because the White House can order several agencies to get together. So far, we don't know of any hearings that they're going to be holding or asking for input, but it's a good sign. I think it's faint on the horizon, but a good sign. We've also been hearing about lots more fentanyl showing up in the streets. It's basically impossible to get hold of heroin now in most big cities because it's being laced with fentanyl. Fentanyl is a good drug. It's used in babies for anesthesia. It's used in animals because you can give it under your tongue. So it's a very good anesthetic, but it's not good in the streets because people don't know how to use it.
Right.
It's very powerful from the standpoint that a teaspoon of it is worth a lot more than a teaspoon of heroin. So when they mix it in with other things, people are accidentally liable to get too high a dose, and this could be behind the increase that we're seeing in street overdose deaths that was announced by the CDC. If anybody hears of any fentanyl, it's really a good idea to tip off the DEA. Tip-offs are very important in the police department. You don't have to be sure of something, but police departments, whether it be federal or local, operate on tips. It would be really good to clear this stuff off the streets because I'm afraid we're going to see lots more deaths because of the dosage errors. Mm-hmm. Also, there was some news out of Oregon. They are still trying to cut off all the patients with Medicaid insurance. And there was a very strong editorial written in the Wall Street Journal. So this will help the cause, I think, now that there's gaining national attention.
That's wonderful.
So, Janelle, do we have anything in the mailbag today before we start our topic of palliative care?
We do. Someone asked, Dr. Kline, why is there a knee-jerk reaction to the CPP community and there's nothing to replace pain medications, yet they want to take them away?
Good point. It's hysteria, mass hysteria. If we had other alternatives, it would be fine, but the only alternative to opiate pain medicine and fentanyl, by the way, which is not an opiate, is Tylenol. There really isn't anything else that works. Mm-hmm. And it has to do with the brain chemistry matching the chemistry of the stuff that oozes out of this plant, which is God's gift to humanity, as one famous doctor put it. It really is an amazing medicine. It's all natural. It has very few side effects. 1% of people may become addicted, and if they do, they can handle that. Much the same as 1% of people who use certain drugs for their arthritis may get an infection and die. So it's just been demonized. It's really sad how this has happened. We're the only country in the world that demonizes opiates. All the rest of the countries in the world think this is still the number one drug for pain, and it is, period.
Okay. Another question from Aaron Sells from YouTube asks, Dr. Kline, can you comment on the assessment of the recently published 2017 opioid overdoses in the New York Times.
In the New York Times? I didn't read that. The problem is that, you see, rather than centering our discussions and critical thinking on what's gone wrong for 100 years and why aren't we any better, they're still playing around with numbers. Like, so what? Lots of people die from opiates in the streets. These are all street numbers. People don't die from overdoses in medical practices. I asked 4 pain doctors who combined have practiced 125 years. And I asked them, I said, how many people in your practice have died of overdoses? And the answer surprised me. It was almost none.
How did they?
And then I got to thinking about the difference between dying on the street from heroin injected intravenously and dying from pills. And there's a big difference. If you take the same dose of heroin and make a pill out of it and take it on a regular basis, you're not going to die. But if you shoot it into a vein where you suddenly get a peak blood flow,
you've been listening to The Doctor's Corner with Dr. Kline.
So basically all the monitoring that's going on by the police departments and APRIS and Brandeis University is they're monitoring people that are not going to have the problem. They should be monitoring people who are in the addiction community, but they can't because they don't go to doctors, they don't get medical care, and they don't end up on computers. So we are chasing the wrong dog. So
what do we need to be chasing?
We need to be chasing what is going on. We need to start real basic. What is going on? What is going on is the government has made heroin illegal and as a result has created a crime network. The crime network then provides people with addiction disease. We call this type B addiction disease. This is real brain biochemistry addiction disease that should be treated with MAT, medication-assisted treatment, but it's not. Okay, so we've admitted that we have a disease that needs to be treated with medication-assisted device. There was a study the other day that said almost nobody's getting it because people really don't want to give it to them. I cannot give it to them. I have to have a special license from the government. If I was in Canada, I could give anybody anything. Some addict person with addiction disease walks in the office, I could treat them with MAT, medication-assisted treatment. So then we have to realize that the drug itself is not the demon. The demon is the addiction disease, the brain disease, and has to be treated medically. And we need to stop demonizing anybody who swallows these pills, and that would be the pain patients. And so we're going to talk about palliative care tonight and how that can help.
Before we do that, because we've had a lot of questions about why isn't like the CDC or the government and stuff going after the illegal fentanyl and heroin. Is it that simple?
Yeah, no, it's that simple. Police departments get their funding based on the number of prosecutions. It's much harder to catch and prosecute drug lords. I saw one the other day who had 60,000 pounds, I don't know, some horrible amount of cocaine, and he was being marched off, for 37 years in prison. That's the first I've heard. See, those are hard. Those are hard prosecutions. Prosecuting doctors and nurse practitioners, that's easy. The funding for the federal police and for local police departments depends upon the number of arrests. It's real simple. So if you can arrest or at least charge a bunch of doctors, wow, your numbers go up. Next year you get more money. Pretty simple.
Okay. We have a caller from area code 980. What's your question for Dr. Kline?
Hi, Dr. Kline and Janelle. This is Jessica.
Hi,
and I kind of had more of a comment. There's a lot of questions about the CDC and, how they're basically tracking people or where their numbers come from. So I actually worked with about 5 people on this, and we tried to decode their last report, at least the last one I know of in June. And they basically have two codes. There's one that says opioids, which is not a word, like you said, opioids without methadone and those with. So regardless if you drink 3 bottles, huge bottles of alcohol, along with a 5 milligram Percocet, something like that, or take a benzodiazepine, if you have any trace of an opiate in your system, in the deceased system, it will count as that. It strictly goes to that.
Yeah, they've been doing that for a long time. It's a very dishonest way to do it. If you die of 5 different things, including alcohol, then there are 5 deaths recorded, 1 for each one of the categories. It doesn't change the total. The total might be 72,000, but if you add up all the subcategories, it adds up to more than 72,000. That is not the way you do it in medicine. The problem is the CDC are a bunch of scientists, and they are not doctors. You know, if somebody dies of 3 different diseases, you know, you just pick the most common one. You just say die of multiple diseases. So it's scientifically dishonest, I have to say, to do it that way. If they wanted to break it down, they would have to break it down by alcohol only, heroin only, prescription drugs only, cocaine only, but they don't do that. And we need to have them join a roundtable and ask why they are doing it that way, because it's very misleading. I wrote the CDC and I asked them how many people actually die from prescription opiates like you would get at the office only.
Do they know?
They didn't answer me back. In spite of several requests over 3 months. So I think they're hiding something. I mean, we've already seen that there are estimates of opioid overdoses. But we need to stop for a minute. These are only deaths in the addiction community. These are not people dying in suburbia. Or these are people who are not under medical care, who are desperately trying to get anything they can to treat their disease, since MAT is not very effective, and they are dying in the streets. This is street overdose deaths. This has nothing to do with the general population, but they made it seem like the general population, and I'm sorry, that's not honest.
Right.
You don't take data from one population and apply it to another different population. If I did a study on women from 17 to 35, I could not apply the results to women 60. That's just a basic rule, and they are violating basic rules of science. So you're correct, Jessica.
Okay. Let's start getting into what we were going to talk about, the main topic tonight, and that's palliative care. You believe that this can possibly solve the entire issue that's going on right now? And how so?
It really can. First of all, the CDC regulations, if you pull them up, in the very first sentence, it says that palliative care and hospice care are exempted. So you can just stop reading the CDC guidelines. Palliative care is exempted. Most all states exempt palliative care. It's because they're just copying from one another. But that's okay, because when a state says that palliative care is exempted from the rules, that protects the people from having cuts in their medications. It's law. So what is palliative care? It's I just got this downloaded from NIH. NIH, you can plug in NIH palliative care brochure, and you'll get the 18-page brochure. And so NIH, which is our mothership, you know, for medical issues, palliative care is a comprehensive treatment of the discomfort, symptoms, and stress of serious illness. It does not replace your primary treatment. It works together with the primary treatment you're receiving. The goal is to prevent and ease suffering and improve the quality of life. Such things as pain, breathing difficulties, nausea are symptoms that will improve the quality of life The disease itself may not have an immediate cure. For example, if you had bad influenza, were in the hospital having trouble breathing, you would probably not get palliative care. But if you had chronic obstructive lung disease and had trouble breathing all the time and you were short of breath, then you would qualify for this extra palliative care. So what is it? It's just old-fashioned medical care. If a person comes to a doctor's office and you can't solve the underlying problem, they may have interstitial cystitis or lupus or rheumatoid arthritis or osteoarthritis. There's a whole long list of diseases that we can't immediately get rid of. So what do? You just throw in the towel, say, see you later? No. Our profession treats people for pain and discomfort. That's what palliative care is. Now, if we kind of brought it down to just a couple of notions, one, these are diseases that you have difficulty curing. Two, these are diseases that have symptoms that if you treat the symptoms, the quality of life will improve. The quality of life is mentioned multiple times in the NIH brochure. And three, we've added that it may affect your lifespan, but what disease doesn't? And that's to avoid confusion with hospice. Hospice is actually a subdivision of palliative care. Hospice is palliative care for people at the end of life. What's confused it is Medicare has a program called hospice. It's called a prospective capitated program, which simply means if you have a Medicare-approved hospice agency, they give you a sum of money to take care of each patient. If you have palliative care status, or the three things I just mentioned, there's no official program. In other words, in my office, if I see somebody and they have a disease that doesn't look like it's readily treatable, they have some sort of bad symptom, like I had somebody the other day that was coughing. Just couldn't stop coughing, was up all night, and so a little bit of codeine helped them stop coughing. Some people with their terrible GI disease have constant diarrhea and they can't leave the house. So the palliative care experts look at it from the standpoint, let's see if we can stop the diarrhea. I know we can't stop the disease, and you can actually still receive treatment for your basic disease, but the focus is on improving the quality of your life. Well, I have not corresponded with any person on my Twitter feed, which is now 20,000 and something, who does not fit the diagnosis of palliative care. It's even a diagnosis. Who can make diagnoses? There's only one group of people that can make a diagnosis of any type. You have to have a medical license. Nobody else can establish diagnoses. And this includes doctors, dentists, anybody with a medical license, nurse practitioners, physician assistants, advanced nurse practitioners. All of these people have medical licenses. All of these people are entitled to make the diagnosis of palliative care.
Why is this not being used then more often? Because so many people have actually gone in and have done what you said as patients and let their doctors know about it, and they often turn them away. Why is that? What's going on there?
It's ignorance.
Okay.
It's just ignorance. Ignorance is not necessarily a bad word. Ignorance just means you don't have the facts.
Right.
A lot of doctors don't know what this is. If you ask the average doctor what palliative care is, he says, "Oh, it's something for dying people." It's because it's never taught officially. And of course it should be. There's palliative care teams now in lots of hospitals. You can train in palliative care and get a certificate, blah, blah, blah. There's a giant book on palliative care, which I have. Palliative care includes things like radiating tumors that are in the wrong place and are hurting people. You just blast it with some radiation. You're not going to cure the disease, but you're going to make people feel better. Women with metastatic breast cancer using a radioactive isotope, strontium-90, you can irradiate the metastases in the bones and make people feel better.
Yeah.
That's palliative care. And of course, relieving pain is the essential part of palliative care. Doctors, I'm afraid, are just ignorant of the facts, and sometimes when we send them my paper, they just ignore it. Like, well, what's this? This is why we need an official U.S. government definition of palliative care. It's too bad because it's against the law for the federal government to interfere with the practice of medicine, and basically setting this would be interference. But I think in this case, if they did that, the physicians would wake up and say, okay, these are the 3 points of palliative care established by whoever wants to establish it in the government, maybe NIH, because they put out this little brochure. And then, you can say, okay, well, who's palliative care? Okay, here's the criteria. Oh, my goodness, all of my chronic pain patients fit. So if there are laws protecting palliative care patients from reductions in medications, that would solve the problem. Bam.
So right now there is no laws for palliative care at all.
There are laws that include it as an exemption. In other words, whenever the states say, okay, you're only going to get 7 days of this, and you got to do this, and 90 milligrams, blah, blah, blah. But if it says in the beginning palliative care is exempted, then you ignore it. You can ignore all the CDC guidelines.
Yeah, don't
you
they
can
say
ignore all the but and then the states don't establish what palliative care is, and since people don't know it, it's vague. I mean, it's basically old-fashioned doctoring and taking care of the patient's needs. And if a patient is in pain or coughing or has terrible bone pain, then you'd zero in on taking care of the symptoms.
I did a quick search on Google for palliative care before we started tonight, and it only came up with end-of-life stuff. So it even...
Yeah, it's confusing, but, the NIH, fortunately this NIH brochure came out. By the way, it's NIH nursing. This brochure came out. There's nothing in here about end-of-life. And as a matter of fact, if I can find it, it basically says that's not the case.
Yeah.
So, in other words, we have to get a federal definition that excludes end-of-life. You can make end-of-life a subcategory of palliative care and call it hospice.
Okay.
But, yeah, you're right. We have the wrong impression. And when palliative care was started, it had nothing to do with end of life. It was just people with bad disease.
Yeah.
Dealing with serious disease, says NIH, can be difficult. Okay. And so what it does is it expands the team. If you've got a serious disease and you have an oncologist and a radiologist, well, this expands the team into pain experts, internists with pain expertise, pharmacists that can help a lot, with picking the right pain medicine. Basically there's 2 plans currently in effect for me as a doctor to follow in the treatment of pain. One is the FDA, and the FDA tells me that I should titrate the drug, which means I gradually increase it, irrespective of the number of milligrams. FDA is the legal authority on medicine established by Congress. And then we have the CDC guidelines, which I don't follow because they exclude palliative care because all of my patients qualify for palliative care. So we doctors have 2 that we can choose from. And obviously the one that's legally established, the FDA, is the one to follow. Any other agencies are giving their opinion, and if they're giving their opinion, then it's my right to reject the opinion.
Okay.
FDA does not publish opinions. They publish science about how the medicines work, what their recommendations are based on the science. FDA is science, CDC is opinion.
Okay.
So doctors can choose what they want to follow, the opinion people, or they want to follow the science people.
We have a few calls. Caller from area code 303. What is your question for Dr. Kline?
Hello?
Hello. Hi, how are you tonight?
Oh, hi. It's Lovett, Patty, from the chat.
Hi, Patty.
And I'm so happy you're talking about this subject tonight because it's something that, I'm looking into and actively seeking. I was told something, and I wanted to ask you, Dr. Kline, if there's any truth to this. I was told that it would be better to have, like, what do they call Medicaid, Health, and Human Services come in and do an assessment of you before you do the palliative care certificate and information. Is that any truth to that?
No.
Excuse me, I have a cold.
No, okay, no, that's not true. It's a diagnosis.
Okay.
They don't send in a team to make a diagnosis of cardiac disease or pulmonary disease. This is a diagnosis. Only doctors and PAs and nurse practitioners with medical licenses can establish any diagnosis, so you were informed incorrectly.
And we have another caller. Caller from area code 662. What's your question for Dr. Kline tonight? Hello, caller from area code 662. Hi, how are you? What's your question for Dr. Kline tonight?
Hi.
You there?
Hello?
Yep, we're here.
Oh, hi.
Hi.
Okay. I have a rare form of epilepsy that's on both sides of my brain. I have a mass in my left temporal lobe, which causes the grand mal seizures, the PM seizures, and then it's all scattered out across the top and the right. Well, I also have IBS, arthritis, neuropathy, high blood pressure, PTSD, and a number of other things, are degenerative disc disease. But my father recently went on hospice just in the last month or so for me to take care of him. And it is very difficult for me to do this with the epilepsy. I've been under a lot of stress trying to get him help because he's a veteran and the VA didn't want to give him his medicine, and he had 2 strokes due to all this opioid crisis. He's on hospice now, and he's getting his medicine, but it has caused me to be in a more, I'm having more seizures.
Yeah, can you frame this in a question? Maybe we could help you answer it.
Okay, what I'm asking is, what could I do in order to get any type of help so I can take my medicine? Because when I have the seizures, every
now it's your father you're taking care of?
I don't know. Her phone is messed up.
That's all right.
Sorry about that. Well, what would people do in that situation? I mean, I guess.
Well, first of all, veterans can get home services. It depends on whether or not they were enlisted during the any war zones. It's a complicated, but in every single town there's a VA agent, and you find them, and the VA agents can help you find services from the VA.
Okay. To get back to the palliative care thing, so what ways can we get, do doctors ask to get this placed in? I mean, can patients, how would we implement this?
How to get it started, yeah, good question. One of the things for patients with palliative care is they require more care in the office. And so I wrote a paper on palliative care that shows doctors how they can be paid for the extra time they're spending. A lot of doctors don't want to deal with chronic pain and chronic disease in general because they're not compensated for their time.
Yeah.
They may spend 2 hours outside of the office visit, working on somebody's case. There's no way to get paid for that. But now there is. And it's all discussed in the palliative care paper, which people can get if they go to Thomas Kline MD. That's Kline, Thomas Kline MD, all one word, .com.
Okay.
And my son-in-law has set up a little single-page website where you can press on the Medium button where I have the articles and read the article on palliative care, make a copy and take it to your doctor or send it in ahead of time, which is better. And the palliative care also involves being able to spend more time with the case when the patient is not in the office. The rule before was you couldn't charge for any time that you weren't there face-to-face with the patient. Now you can, and it's a very good system, and the CMS, Medicare administration, has made it very nice for people in primary care to take care of chronic disease, chronic pain, chronic lung disease, chronic anything, and be paid for the extra time.
It'd almost be
So
like
I think
lawyers.
That's important.
Like billable hours.
Like lawyers. Lawyers don't do things for free. They charge, for everything they do, and that's what we should do as doctors. So making a copy of that palliative care paper on my little website there, send it into your doctor in the mail ahead of time, and they will read it and see that they can make a little extra money. Not that doctors are greedy, but nobody wants to work for nothing. Right. If your boss says, I'm going to pay you for 8 hours, but I want you to stay 10 hours, well, that's what we're being asked as doctors to do, is to take complex patients that take a lot of extra time. So the palliative care paper has two purposes. It teaches doctors about palliative care and the fact that it's exempted in most states in the CDC, which is real important. And then, of course, how they can bill for the time that they're spending. So.
But more than just patients taking this in and pushing it for doctors to, listen up and understand this more, who actually makes these changes? Who has the power to do that? Is it all on the doctor side? And how, is this going to be a law that has to be placed in?
No, it's just through education of physicians.
Okay.
It used to be we'd go to conferences every year, but people are working in these sausage factories now because they've working for other people who say, no, you can't take off and go to conferences. We can't afford you to do that. So doctors don't go to conferences anymore. They don't read textbooks anymore. They go online. Well, Medscape is what doctors read a lot. It's just a private website. You can put anything on there that they accept. You don't have to be an expert. You can just, write anything you want. Used to be we would go to a conference and the people speaking would be the experts. They weren't paid by anybody. They would be the experts, and they would talk about palliative care, and we'd all take notes and go home and do it. But that system is now lost, which is really too bad. And part of it is doctors giving up their independence and working for somebody else, which 75% of doctors have done. So it's a matter of maybe a big, a statement from FDA that, basically most chronic pain patients are really palliative care. And with palliative care, you can be protected, both the doctor and the patient. So if a doctor doesn't want to taper somebody and feels under pressure, it can say, wait a minute, the law says here that palliative care is exempted. That protects me as well. I'm not going to break the law and forcefully taper somebody who does not need to be tapered. So it's a matter of education. The problem is who's going to do it, because all the educational forums that we used to use are gone. And so we get a lot of charlatans out there, too, making money putting on conferences and stuff where they just invite anybody. I get all these things on Twitter. Would you like to speak at a conference in Dubai? And they have no idea who I am. They said, what would you like to talk about? And the other day I wrote back and I said, I want to talk about baldness. I got no response from them.
Yeah.
So you see, they make money setting up these phony conferences, and people flood to them. And they don't even have the experts talking. It's medical education is really a problem. CDC is making it worse because they're running around the country teaching medical students and people in training, residents, that, oh my God, don't give people opiates. They don't work.
Right.
It's just horrifying. If we had nice conferences every year, some of our esteemed physicians could stand up and say, hey, this is a bunch of nonsense, but CDC gets to do what it wants. That's just, horrifying to me. I took one of the CDC courses online and stopped halfway through because it was just filled with things that weren't true.
Really? Wow. Are there any individuals within, like the AMA, the CDC, or the government that are sympathetic towards this cause and this issue right now? that you know of?
I haven't found any. It's pretty shocking.
Wow.
That this wildfire is just so pervasive. It's pervasive in doctors and judges and lawyers and everybody. People believe that this stuff doesn't work and it causes dope fiends, and doctors are feeding the dope fiends, and dope fiends are worse than spies. They're worse than atomic spies. You know, they're worse than the Taliban. The most serious crime in this country is taking drugs, which is kind of ironic because the United States is the world's largest consumer of illicit drugs. And that's not just the addiction community. That's everybody. Parties, cocaine, weed, blah, blah, blah. And then they run around self-righteously saying, oh, but he takes opiates. We ought to lock him up. There was an article in my local newspaper. I just cut it out today. This woman was caught with some fentanyl and some Ativan in a little box, unlabeled. So she's up on a felony charge.
Wow.
She might as well have, held up a gas station or something with a gun. I mean, it's about as serious. So how are we going to change that? Well, that's hard. And we need to see the faces of people who have addiction disease, and we need to see the faces of people who are being let down by the medical establishment and forcefully taken off medicines, which, as far as I know, has never occurred in any medical practice anywhere that I can think of where people are forcefully, without consent, taken off medicines that are working. It's pretty heinous.
Yeah.
And how people are missing it is because of the epidemic of prejudice and fear, just as the fear of communists swept the nation in the 1950s, the fear of witches in 1690, the fear of black folks snorting cocaine, went through the cocaine epidemic. There's always got to be something we're afraid of, and it's fear. We are afraid of these drugs for no reason. The most dangerous drug in this country is alcohol. It kills 250 people a day. Street drugs cause deaths in addicted people 40 to 60 a day, which you read in the newspaper. Whenever you read something in the newspaper about the number of daily deaths, remember this is occurring not in the general population. This is occurring in the streets where there is no medical care.
Right.
So,
we have a few more callers. Caller from area code 570. What is your question for Dr. Kline? Hello, welcome to the Doctor's Corner. What's your question?
We have a few more callers. Caller from area code 570.
Could you please, Ryan? Hello, I could hear them.
Hi, it's Charlene.
Hi,
from Pennsylvania.
Hi, Charlene. Can you turn the volume down in your background? We could hear the echo.
Could you please? Hello.
Hello.
Yes, hi. Could you please turn your volume down, or call us back?
The volume down in your background. We could hear the echo.
Oh, sorry. Hold on.
Okay. Okay. There you go.
Sorry.
That's all right. What's your question? What's going?
So I just wanted to give some people some hope that on that brochure, I actually called getpalliativecare.org, and they say they just need a referral from your PCP, which my PCP agreed to do, and the closest one was only about an hour away from me. And I printed that brochure out, and I brought it to my pain management doctor, and I didn't say anything nasty or whatever. I just said, hey, because originally I had asked my pain management doctor about palliative care, and she goes, oh, no, that's only end-of-life care. I can't do that. So I just nicely handed the palliative care brochure to her, and I said, this was just released from the NIH. I would just like you to put this in my file. And then she read it over, and then she kind of just didn't say anything. And then in my next visit, miraculously, my taper stopped, and I said, I'm working on a palliative care certificate, and I'm going to add it to my file. And so I just wanted to give some hope out there that maybe that number will help, and that, maybe you need a referral from your PCP, but, it is a step in the right direction.
yeah, that's good to hear. The brochure does kind of stress looking for palliative care agencies, And that's one way to do it. We find a lot of them are just not doing pain patients. But the doctor herself can establish palliative care. It's a diagnosis. It's got a number, an ICD-10 number. Like any other diagnosis, we put numbers down for these diagnoses. And so one of the things left out of the brochure is anybody can do this because it's establishment of a diagnosis. And so doctors can run palliative care. They can get a social worker to help out. They can get an oncologist. They can get a radiation therapist to help with painful metastases. And so the primary care doctor really is the one that should be running this. That's what we do. We coordinate care. Now, if you want to go to a palliative care person, then that's like a consultation. And if it works out, that's fine. But the doctors need to understand that they can also do it. Anybody who's legally entitled to making a diagnosis can do it. So it's not a government program. Basically, if you go to a palliative care service, they're billing fee for service. So if you come to my office, I would bill fee for service. The social worker would bill fee for service. The radiation oncologist would bill for service. It's not one of those bundled deals like hospice. Hospice is just a subgroup of palliative care for people at the end of their life.
And it's
so
not,
I'm glad to hear that, Charlie.
Yeah,
that's good.
That's great. Also, this isn't like federal or state. This is just by doctor.
Yeah.
Okay. All right. Awesome.
It's just doctoring. It's comfort care. You know, we always use the word comfort care like it's just for people dying. No, it's not true. You know, doctors provide comfort care for people with all kinds of diseases, right, that we can't immediately treat.
Wow. Well, and I liked how she did it too. I think sometimes if we are too pushy as a patient and want to tell a doctor how or what we think we have, or hey, look at this. Like you've even said, like, don't bring it with you at the appointment, but maybe send it ahead of time because it's hard for doctors to read it. They're, they don't know oftentimes.
And it's new information.
Yeah.
Nobody likes to change their mind,
mm-hmm.
and doctors are not exempted from that. But doctors at least are kind of used to the fact that medicine does change, and so they will give things like this a critical eye. Now, so giving them a chance to read it, though, and not just thrust it at them in an 8-minute visit and expect them to read it. This way they'll a lot of times read it before you come in for your next visit.
How did you learn about palliative care?
Me?
Yeah.
I took a job as a chief medical officer in a little small hospital, and my office was in the old operating room with double doors. And there was a big book there. It was called Palliative Care. It was written in the 50s, and I started thumbing through it. And I thought, good heavens, this is a science. There's a science to palliative care. There's all kinds of little tricks. I mean, nurses know a lot of these tricks. I mean, that's one good thing about nursing. They know how to take care of comfort needs of patients. When I was in the hospital briefly with a little illness, I found the nurses were the best people there because they were trying to make me feel comfortable. Mm-hmm. The doctors just whipped in and whipped out, So there is a science to making people comfortable.
Do you believe that also, instead of maybe fighting against what, like the CDC guidelines that are currently in, and I mean, because that can't be voted out now that it's in like that, is there a way that we can work with what is currently in place right now to be able to change this so we can all be happy, all sides?
Well, yeah, that's a good point. They're not going to change their minds and go, oh, we made a terrible mistake and people are dying. What you do is ignore them. We can use the real guidelines from the FDA, which tells us officially how to treat people with pain medicines, and then we can ignore the CDC guidelines. And if somebody says, hey, you can't ignore the CDC guidelines, yes, I can. That's my prerogative. I have a license, and I'm choosing to follow the FDA guidelines. So that's a very good way to get around the CDC. I think action needs to be taken to stop them from spreading things that are not true to medical students. And that's not their job. CDC has a mission statement established by Congress, and it's got nothing in there about going around telling medical students not to use pain medicines. I mean, somebody needs to step in on that. That's really a serious thing they're doing. But otherwise, in medical practices and stuff, I'll just go with the FDA guidelines, which allows me to treat to any milligram level that works using my judgment, making sure that they don't, get too drowsy or something. The fear is that the longer you're treated with opiate medicines, the more likely is you'll become addicted. And that was already shot down by the FDA. FDA, the one in charge. Who's in charge of opiates? It's the FDA. Nobody else. People can just run off at the mouth and make, quote, voluntary recommendations and suggestions. That's fine. As a doctor, I can look at these suggestions and I can choose not to take suggestions and voluntary things. But I can choose to use legal protocols from the FDA.
We have several calls. A caller from area code 806. What's your question for Dr. Kline? Hello, caller from 806. Are they on? Sorry about that. Caller from 806. What's your question for Dr. Kline?
Yes, this is Melissa Rowan. Dr. Kline, Janelle, can you hear me?
Yes, we can hear you.
Hi, I'm sorry. I can't watch the show because my internet's down, but I thought I would call in anyway. I'm concerned, Dr. Kline, and Janelle, you as well, regarding the FDA and what was deemed a shortage. And now, if you go on their website, you'll see so many medications that have been discontinued. Basically, everything that pain patients and PTSD patients have been taking. Do you know anything about that? I know it's partially because of Puerto Rico, but I'm not certain.
I spoke to a hospital pharmacist about this, and it's coming from the distributors of the medications, and nobody is quite sure why there's a shortage one week in one medicine and a shortage the next week in another medicine. They seem to have enough narcotics to take care of people's pain, but they have to keep changing them. I don't have an answer to that. I mean, if distributors are creating shortages, then the government needs to look into this because they're basically under the control of the FDA, federal, Food and Drug Administration, prescription drugs, across-the-counter drugs, all the drugs. So hopefully the FDA is looking into this. This has happened before, too. All of a sudden, there'll be a shortage of an antibiotic. Somebody needs to investigate. We can't just speculate, but it's definitely a problem FDA needs to deal with, and I think they are.
Okay. We have another caller from area code 248. What is your question for Dr. Kline?
Hello?
Hi. How are you?
Hello.
We can hear you.
Hi,
Go ahead.
This is Jeannie.
Hi, Jeannie.
Can you hear me?
Yes, we could hear you. What's your question for Dr. Kline?
Oh, good. I just wanted to say that I am a chronic pain patient, but I'm also a nurse. And I became a nurse in '92, and we started trying to teach doctors on the floor about palliative care because I was working in oncology. And we were trying to tell them that it doesn't have to be end-of-life care. It's just just like you said, Dr. Kline. It treats patients' symptoms. And none of the doctors wanted to hear anything about it. And that was back around '94, I think.
Yeah, that's a real problem. We need to show them they can make money at doing it. Then they'll become interested. What was the resistance? What did they say back to you? They didn't like it because nurses were bringing it up, or what?
Maybe because it was a separate group that got together to start teaching doctors about it, and I think it was maybe just extra work they had to put into it to learn about it. I don't really know.
Were other doctors teaching them? or just other personnel?
It was a nursing. It was a nursing group.
Yeah, well,
So
that's the problem. Doctors think nurses are idiots, and really it's
Right.
the doctors who are idiots, because doctors don't know anything about patient care. The people that know
Yeah.
about patient care are the aides and the nurses. Nobody else really knows about patient care, and doctors need to defer to nurses. I mean, the old-fashioned doctor's office, remember, was the doctor and a nurse. It's a great combination, you know. It was the nurse who took care of people, and the doctors wrote the prescriptions, you know. Taking care of somebody is a science, and nurses are best at that. And they didn't like it because you nurses were telling them something they didn't want to hear, which is, where I come from, it's called being pig-headed.
All right. We have a few more calls. Caller from area code 662. What is your question for Dr. Kline?
Hi, this is me again. My phone dropped the call. This is Jan. I've been taking care of my father for several months now, and he has just gotten on the hospice care. What I am wondering is how my doctor got his office shut down, but he's coming back. Not for any other reasons other than it was business reasons. It was a business deal. But he's coming back. And how do I approach him with this palliative care as far as myself? Because I have been off. This is where I call craziness over this opioid hysteria thing. I mean, I've been off of opiates for 6 months.
Okay.
Have I suffered? Absolutely.
Well, you need to tell your doctor what you just said to us.
So
in other words, I've tried it, and I got over the initial withdrawal that usually lasts 2 weeks, and here I am 6 months, and here's what's happened to me. Then you describe what's happened to you. Don't talk about the pain. Talk about what's happened to you as a result of being in this much pain. How your life has changed. What things are you not doing that you were able to do before? And look them right in the eye when you're telling them this and say, I am clearly much worse than I was 6 months ago. And then you just drop it. You don't say, like, you're an idiot, why don't you give me medicine? You just drop it. And you let the physician figure it out. It's called the pregnant pause. You just say it, look them in the eye, and then pause. And let the doctor figure out what to do.
All right, we're going to take one more call tonight. Caller, welcome to the Doctor's Corner. What's your question for Dr. Kline? Hello, are you there? What's your question for Dr. Kline? I'm not sure where they are. Okay.
Hello?
Oh, hi. Hi there. Welcome to the Doctor's Corner.
Oh, I wasn't sure.
Go ahead.
I'm sorry, I wasn't sure I was online because I've been listening also.
That's okay. What's your question for Dr. Kline?
Is there any suggestion for someone that has been with a doctor for years that was abandoned and found someone else to take care of them, but now the pharmacy won't take care of them anymore?
You need to find
taking care of them for years.
Yeah, you need to find an independent pharmacist, and you need to go talk to them, not with a prescription that you need to fill. You just go talk to them, and you say, this other pharmacy is refusing to fill my prescription for such and such. Take a little list of medicines that you're on to this new pharmacist and say, I've heard that independent pharmacies are the place to go, and I would like to transfer all my medicines to you and do shopping in your store. Are you interested? And at least you'll find out ahead of time. They say, oh, no, we don't do opiates. Then you just go to another one. I've had very good luck with independent pharmacies. Certainly better luck than the chain pharmacies. The chain pharmacies have corporate policies that are harmful to people by refusing to fill their prescriptions, thinking they're dope fiends. And in fact, dope fiends don't go to pharmacies. Dope fiends get what they need on the streets. So no dope fiends are going to end up in the pharmacies anyway. So it's like being a commie, you know. Hey, you look like a communist. I mean, that's what it boils down to. So find independent pharmacies, but don't go in there with a prescription saying, I got to fill these immediately. You know, then they're going to get turned off. You go in there ahead of time, you know, and say, can I talk to you for a couple of minutes? And I want to transfer my prescriptions here. Usually works.
Well, we're going to wrap up here. Do you have any last words you'd like to say or share about palliative care this evening?
Well, people can go on my little website, thomasklinemd.com, and get copies of the paper on palliative care. I'm working on some revisions, but you take what's there. And there's a little palliative care form. Everybody's saying, where did this come from? Well, Dr. Kline made it up for people to use, but you can make up your own form if you want. It's just a guideline. And start to ask doctors about palliative care. And if your state has laws exempting palliative care, you need to point out to the doctor that if you're going to try to cut me in my medicines and there's a law protecting me, are you not breaking the law? I mean, you can do that as a last resort. Right. Otherwise, you can be nice and say, look, this state has a law protecting us palliative care people, and by the way, protecting you, doctor. Same thing at CDC. Palliative care doesn't apply to anything the CDC wrote. Nothing. Line 1 says, hey, everything here is moot if you have palliative care. So you can say to the doctor, you're not going to get into trouble if you just say that you're going to go by FDA guidelines and not by the CDC guidelines, which are voluntary. It's, you know, I'm kind of sticking to this. Go with the FDA, the legal authority, and CDC is just voluntary suggestions. Well, you know, you don't have to follow voluntary suggestions. And then they say, well, you know, the DEA is going to come and get you. And say, well, doctor, why don't you, how about I get a bunch of you doctors together and hire a lawyer and put them on retainer for you? And of course, they'll say no, but it might give them the idea. Instead of whining about it, you go get a bunch of criminal lawyers to stand by. You pay them a little fee and they'll stand by. And if you get into trouble, they'll come to your aid. You know, protect yourself. You know, it's like buying a gun, except you're going to buy a lawyer.
Okay.
So.
Well, thank you, Dr. Kline, for joining us this evening. And thank you, Carnation, for listening in and asking all your great questions. And we will see you again here at the Doctor's Corner next Tuesday. I'm Janelle Ogway, signing off this evening. Have a good night. Good night.
You've been listening to The Doctor's Corner with Dr. Kline and Janelle Elgway. Copyright 2018 by EXG LLC. All rights reserved.